Everyone. Thank you for attending. It's an honor to just talk to you this evening about hydrocephalus. I would also like to thank the Margaret Hackett Family Program for their support and generosity for making events like this possible. So thank you very much. So let's get started. As was mentioned, I am a neurosurgeon at Comer Children's Hospital. I've been practicing pediatric neurosurgery since I finished my training in 1997. I have a lot of experience with hydrocephalus, and it's one of the conditions that I really working with families, caring for their children and into adulthood. So I'd like to share some of my experience. This is kind of the objective for tonight's webinar. I'd like to um, I know it's a general audience, but help you understand what hydrocephalus is, how it's diagnosed, and the common tests that we sometimes use in the evaluation of children and adults that have hydrocephalus. I want to learn a little bit more about the various treatment options, including the role of shunts and the different endoscopic procedures and what to expect from each. And then also how to support your child or yourself after treatment, including follow-up care and when you really need to seek medical help. So this will kind of serve as the introduction. We'll get right into what is hydrocephalus, the symptoms and signs that you need to be careful of or watch out for, how doctors diagnose hydrocephalus, what the treatment options are, and then living with hydrocephalus, and hopefully some time for questions at the end. So many of you already know a little bit about hydrocephalus and what this is. And this is just a kind of a drawing, a cartoon, if you will, representation of how our brain works with regards to the fluid within it. So our brain is a hollow structure, and it's filled with what we call cerebrospinal fluid, which is a liquid that looks very much like water, has a lot of sugar, electrolytes, and other important things in it that kind of bathe our brain, it buoys the brain, and it has some other important physiological functions. It starts out in these green areas, which we call ventricles. There's four ventricles, actually, the two lateral ventricles, the third ventricle, and then this fourth ventricle. And eventually the fluid leaves the brain. It's this kind of aquamarine color, surrounds the brain and surrounds the spinal cord. And then eventually it gets reabsorbed into the bloodstream. The fluid gets kind of taken back into the large veins that are inside of our skull. And this is kind of a view from the front. So this is the inside of a vein. And these are the structures that transport the fluid from the spaces around the brain into the veins back, so it goes back to the heart. That's how the normal system works. At a simple level, what hydrocephalus really is the buildup of fluid because there's an imbalance between the amount of fluid that we're making and the amount of fluid that we're reabsorbing. As an adult, we make about a pop can full of spinal fluid every day, and it's continuously made throughout the day, about 25 milliliters per hour, and it's continuously being reabsorbed. There's rare conditions where someone might make a little too much fluid. It's a certain type of brain tumor where that can happen in, but that's very unusual. Most of the time, it's because the fluid has a difficult time getting to the site where it's absorbed, or it's just not able to be absorbed properly. So the problem then becomes the fluid builds up, and it's typically associated with an increase in the pressure inside the head, which is not good for the brain. And there's certain types of conditions. You can see here, this is just an example. Here's another schematic representation of how the brain looks. These are the green ventricles. Here's the third ventricle. There's a very skinny channel called the aqueduct that takes the fluid from the third ventricle to the fourth ventricle, where it eventually gets outside. And you can see here, this is a child that has a brain tumor kind of near the pineal gland. So it's blocking fluid from getting into the fourth ventricle. Here's another type of brain tumor of the brain tissue itself, where the aqueduct, this little channel that should be here, is blocked. And then this is a teenage girl who had a condition called a Chiari malformation, where there was so much compression here at the base of the skull that the fluid couldn't escape the way it normally would, so it was building up upstream. You can see everything else is open properly, but the fluid just is not able to exit the brain as would be in this diagram on the right. Trying to advance here. Okay, so that's one kind of group of patients. Just another large group of children that we have to care for are those kids that have had previous hemorrhages in the brain. So this is a condition where, due to the prematurity, the brain immaturity, the blood vessels within the brain can leak blood, and you wind up with fluid that mixes. The normal fluid mixes with blood. So this white stuff here is some hemorrhage that's happened within the ventricle. And then this is an MRI later where you can actually see the white stuff is the fluid, and these like grayer areas are some of the blood clot and debris that's kind of accumulated in the ventricle. And you can imagine that fluid is normally like water. It's crystal clear. But when you put a lot of blood in and the breakdown products, it becomes much thicker, almost like syrup at times. And that is very hard for the body to reabsorb. So that leads to the accumulation of fluid. And then there's some children and adults too that have what we call communicating hydrocephalus, where everything is open, all the pathways are normal. It's just that the brain has a difficult time reabsorbing that fluid. And we call that communicating hydrocephalus. You can see how everything, all the normal passages are open, but the body's unable to reabsorb that fluid. So hydrocephalus generally has certain specific symptoms, but a lot of times they vary depending on the age of the patient. Infants, young infants, one of the most common signs is the head is growing very rapidly. That's why a pediatrician or the neurosurgeon pay close attention to an infant's head size during their routine physical examinations, because there's normal curves that we can plot those against. We can plot those measurements against to see if the head circumference is growing at an appropriate rate. So it really depends on the age of the child and what the measurement is, and these kind of charts are very helpful. But if it's growing too rapidly, that may be a sign that something is building up on the inside. Another common sign is that the soft spot or the fontanelle starts to bulge, become very full or tense. They can become very irritable. The sutures, the joints between the different bones start to separate. So normally you can't feel a gap, but in some babies where the head's growing very quickly, you can. In older children, headaches and vomiting are very common. The vomiting is a reaction to the pressure in the brain. The brain doesn't like to be under pressure like that, so certain centers in the brain become activated and it causes you to vomit. Vision changes are another kind of frequent presentation, or kids that are good school performers, but then they start to really have difficult time where their progress really kind of goes in the wrong direction. And as we get older, when adults develop hydrocephalus, they frequently have walking problems, and memory changes, and even urinary incontinence issues. So it depends. The symptoms really vary by age. Again, kids, this is what we're talking about. Here's a head circumference growth chart. This is a newborn that had a very large head circumference. You can see it's way off the chart. The average is this heavy line here in the middle. It's about 35 centimeters at birth for a boy. This kid was at 48 centimeters when he was born. So it's a very large head size, and that's clearly abnormal. You can just get a sense how large the head looks. Vomiting, fussiness, lethargy, these are all important symptoms. The fontanelle was full typically. The bones in the skull are separated. The skin itself looks very thin because it's getting stretched. It can look shiny almost, and the veins on the scalp can be very prominent looking. And if it keeps going on without the ability to, or without treatment, then they can oftentimes have a difficult time looking up. So their eye movements are almost pushed down. And I'll show you a picture of that in a second. And rarely, but when seizures can also occur. And when that happens, it's usually because it's been really untreated or left uncared for a while. And this is what we mean. Usually, when you look at a child's eyes or an adult's eyes, you don't see the white of the eye above our iris. But in this case, the eyes are driven downward. So you can see that. That's some people call that sunset eyes, where the eyes are kind of sunsetting down. That's a danger sign. When you see that in a child with hydrocephalus, that's something that needs immediate attention. Toddlers, the presentation's a little different. Vomiting and headaches are very frequent. They may complain of headaches, but if they're too young, they're not talking, they can be much more irritable than usual. There's no rhyme or reason to it. You can't really figure out what's wrong. You take them to the pediatrician, their ears are checked, they're fine, they're teething, but that's not really an issue. Lethargy is another indicator that the pressure is getting high. So these are really cardinal features of hydrocephalus. The big head, we talked about loss of developmental milestones where the child's crawling, starting to walk, and then those milestones start to regress. And again, a late symptom can often be seizures. So when we're kind of meet a child where we're worried about a condition like this, there's different imaging modalities that are available. And it depends on the age a lot of times. It also depends on the clinical scenario. So in a newborn in the neonatal intensive care unit, we frequently obtain ultrasound because moving a little baby like that around the hospital is not uh, the nicest thing to do or the safest thing to do sometimes because they're so fragile. Even just a mild temperature change in the MRI can be too much for them sometimes. So an ultrasound is very easy. It's non-invasive. We have nice pictures of the brain. Ultimately, if we need more information after getting some screening testing, then we can go to a more advanced technology. CT is another very helpful adjunct. They're used a little less frequently today than they had been in the past due to concerns for radiation, but with current imaging standards, the amount of radiation that's actually administered is quite low, but it's still something that we try to limit. The nice thing about a CT, it's very fast. It takes just less than a minute to get a head CT when you're in the machine. So it's primarily used for an emergency situation. If a child comes in with concerns for a shunt malfunction and they're very sick, we just usually go right to the CT scan because it's so quick. If you're worried about hemorrhage, acute hemorrhage, things like that, that's another ideal modality. But MRI really kind of is the best of all of them, and it gives us so much better detail. And you can see the difference here on the right compared to the other studies. You really get a sense of what the brain looks like. But in some cases, it's difficult because kids can't stay alone. It's hard to explain that to a toddler. They have to sit still in an MRI tube for several minutes to get a scan. So there are quicker technologies. People call them fast brain MRIs or MR ventricles, where they can take just a couple quick pictures. But even then, sometimes kids just have a difficult time tolerating that. And another common imaging study that we use is what we call a shunt series. So if somebody has a shunt and we're concerned about it might be a break in the hardware, if the catheter has become too long, or it might have been dislodged, or if there's some separation of the tubing from the brain where it attaches to the valve. These are ways, that we can look at that with just kind of a set of X-rays. Again, these can consist of some degree of radiation, so we like to minimize that as much as possible, and unless we have a specific clinical question. So here's a couple, like I said, I showed this previously, but this is, so you can see the high quality that gives us a lot of information on an MRI, what the anatomy is, what we're dealing with, what the diagnosis is, and then how can we treat this. Clinical hydrocephalus is a common problem. It's about 1 in 3 for 1,000 live births. It's actually the most common neurosurgical condition in children. It's estimated about 400,000 children in the world annually are diagnosed with hydrocephalus, and about 50% of those are congenital hydrocephalus. Depending on the region of the world you live in, post-infectious hydrocephalus plays an important role. In some parts of the world where spina bifida is much more prevalent, that's also an important cause of hydrocephalus. So spina bifida occurs in about 46,000 cases annually around the world, but again, it varies by region. In countries where they supplement the flour with folic acid, the number of cases has decreased dramatically, but in places like Bolivia, where the primary starch in their diet is corn-based and they don't supplement that, the incidence is very, very high. So it depends on the region. And the reason this is important is because up to 50 to 85% of children with spina bifida will develop hydrocephalus and require a ventriculoperitoneal shunt. So it's quite a problem. When we classify hydrocephalus, there's different ways people talk about it. Some people call it obstructive or non-obstructive, but in a sense, all types of hydrocephalus that are obstructive somewhere. The fluid is obviously not getting absorbed like it should be. So that doesn't help us that much. We often hear the term communicating or non-communicating. That's another good way to describe things. It helps us also formulate a treatment plan because we know that if it's a communicating type of hydrocephalus, then certain treatment options may be ruled out or less likely to succeed than if it was, say, in a child with communicating hydrocephalus. So here's a kid where there's a blockage of the cerebral aqueduct because he has a tumor in the midbrain. You can see the lateral and third ventricles up here are very large. The fourth ventricle is normal. This kid would be an ideal candidate for an endoscopic third ventriculostomy. But in a child here where the CSF pathways are already open and communicating, to do that procedure would likely not really help very much. So that's why this distinction is very important. But really the most effective way to describe the different types of hydrocephalus is based on what causes them. So there can be multiple congenital causes. Some kids are born with congenital aqueductal stenosis. They can have a neural tube defect like spina bifida. There can be other genetic syndromes that lead to hydrocephalus and lots of other issues like brain cyst or a thing called Dandy-Walker malformation. In the United States, one of the most common causes of hydrocephalus is post-hemorrhagic hydrocephalus. So kids that have had hemorrhage in the brain due to their prematurity or other bleeding tendencies, if they had a vascular malformation or something like that. Infection is another common thing, not as common in places like the United States, but in parts of Africa, Asia. It's one of the most common causes for hydrocephalus, particularly in areas where tuberculosis is endemic, because that can cause tuberculous meningitis as well. And then there's lots of other reasons. So brain tumors can lead to hydrocephalus. Head trauma rarely, but it's possible. Vascular lesions, like if an adult has an aneurysm that ruptured, that can lead to hydrocephalus. And then there's some other things that are not common to children, but idiopathic intracranial hypertension or pseudotumor cerebri can affect adolescents. And then normal pressure hydrocephalus is a condition that generally affects the elderly. It's estimated there are about 700,000 individuals in the United States that have normal pressure hydrocephalus, according to the Hydrocephalus Association. So in terms of treatment, sometimes our decision making is very easy, if you will. It's if the ventricles are large and there are clear signs of elevated intracranial pressure, then the decision to treat is obvious. So in a kid like this who has severe ventricular enlargement, you can see all the white stuff, all the fluid within the brain. The pressure's high, they have rapid head growth, they're vomiting, they're lethargic perhaps, and their eyes are looking like this, then the decision is straightforward. They need some type of CSF diversion, something to drain that CSF permanently. Whether that's a shunt or some type of endoscopic procedure, they need treatment. We'll go into the different options in a minute. There are some kids, though, that have prominent ventricles, or ventricles may be larger than normal, but otherwise doing well. And they're the ones where it's a little more difficult to treat. And there's not an easy answer for that. That's really based on uh, the the findings of imaging, the physical exam findings, and oftentimes a long discussion with the neurosurgeon and the family to decide what the best options are. We know, though, without treatment, it can cause a lot of problems. Hydrocephalus can cause a lot of issues. So it can cause secondary brain injury if the pressure rises and rises and rises. It's not a situation that our brain likes. It's detrimental to the development of the brain, but it also injures the neurons. It damages the cells that line our ventricles, the ependymal cells, but the nerve cells throughout the brain don't really like high pressure. It affects their ability for oxygen to get to them, so it can lead to uh, cell death at times if it's severe. So if the pressure goes very, very high and it's not treated, that can be a life-threatening condition. And the last thing we want to do is compromise neurological development any further. So we want to get that treated as quickly as possible if once it's diagnosed. It's important to note too that in terms of treatment, there's really no long-term non-surgical treatment for hydrocephalus. There's really no medication that will work to take care of the hydrocephalus. On rare occasions, a diuretic might kind of decrease the amount of fluid that our brain makes, but that's not a permanent solution. There's a diuretic called Diamox, which can decrease the amount of CSF production, but it's a very temporary thing. It's really used sometime as a bridge to when a shunt revision or some other treatment might be necessary, or in persons that have pseudotumor cerebri, but for the most part, they're ineffective in treating hydrocephalus. So they're really not recommended in children because of the metabolic disturbances that they can sometimes cause. So when we make a decision to treat, we really have to consider the available treatment options, and that depends, number one, on the cause of the hydrocephalus. Number two, the age of the patient. Some things work very well in certain age groups and less well in other age groups. And also, what are the associated medical conditions? If we're thinking about a ventriculoperitoneal shunt in a child where the shunt's going to go into the abdominal cavity and they've had previous abdominal surgery or, say, an active infection in their abdomen, then obviously that's not a place that we can use. So really what it comes down to is, do we decide to go forward with a shunt, or can we use some type of endoscopic procedure to perhaps avoid needing to place a shunt? And that's what we're going to get into now. So we'll talk about shunting procedures, some examples of cases and indications, and just what shunts look like, how they work, and how they're put in. And then we'll talk about the procedure called an endoscopic third ventriculostomy, or ETV, which is essentially a way that we can treat hydrocephalus without the need for implanting a device, by creating an internal bypass, if you will, for the CSF to flow. So this is what a shunt looks like, and many people on the call are familiar with this. So this is what we call a ventriculoperitoneal shunt, where it goes from the ventricle There's a valve here and then a long tube that takes the fluid to the abdominal cavity where it can be reabsorbed. There's other variations. This is a ventriculoatrial shunt, so the shunt is placed into the jugular vein and the fluid goes right into the right atrium of the heart where it's just returned directly to the bloodstream. Here, the fluid is deposited into the abdominal cavity, then the body can go ahead and resorb that. It's very, very proficient at doing that. So the most common type of shunt that diverts CSF is like you're seeing here in this color drawing. It has this drawing. It has the same thing, a ventriculoperitoneal shunt, which is the A, and the ventriculoatrial shunt. These are some of the most common types of shunts that we put in. The peritoneum is the target for the VP shunt. It's actually within the abdominal cavity. That's what the peritoneal cavity also means. It's the most common location. It's very well tolerated. Um, it doesn't cause pain or discomfort. The fluid gets absorbed very well. The problem with the VA shunt is it's very um, dependent upon the proper placement. So if it's too long, it can wind up in the inferior vena cava, which is not good. There's a higher infection rate. And if as the child grows and it starts to pull out of the heart, then it may require frequent revision. So that's why it's not the first choice for most surgeons when we have to put in a shunt. So that's one of our alternate sites. Sometimes in older kids where they have good lung capacity and not a really bad history of like asthma or other lung diseases, we may use the chest cavity in certain situations if the abdominal cavity is off limits. And rarely there's other choices like the gallbladder, which are very, very, very infrequently used. Um, Shunts are really made up of a couple different parts, three parts in particular. There's a catheter that goes in the brain, and if you look very closely, you can see at the very tip, there's just these tiny little holes that kind of are just along the first centimeter or so of the catheter, and they're very small, so you can see that's, you know, part of the reasons that shunts can get obstructed. Those little holes can become blocked by tissue in the brain, or they can be kind of embedded in the brain tissue themselves. Obviously, we can't put a tube in the brain the size of your little finger because for obvious reasons. So it has to be small because we're replacing it, but that's one of the drawbacks where these tubes can become obstructed because of those small little inlet holes that let the CSF get in. The next step is the valve, and there's lots of different types of valve. I'll go into that in a second, but the valve essentially is a device that limits the amount of fluid that drains. If you just had a straight tube that drained all the fluid out of the brain, it would just happen very quickly. It would be disastrous because there really has to be the brain would just collapse and sag. So that's not a good thing. The valve is there to just let fluid drain when the pressure goes above a certain pressure level inside the brain. If the pressure is low, it doesn't drain. If it rises above a certain level, it drains until the pressure falls again, then it shuts. So it's constantly opening and closing throughout the day. And there's different types of valves. Some of them are fixed pressure valves where it's just set to one pressure range. That's it. That's the way it's manufactured. And there are others that are programmable where essentially they can have 5 or 7 or more settings in the valve that can be programmed by holding a special device over the shunt and changing the setting right through the skin after it's implanted without needing another operation. Um, and then we have the third part of the shunt, which is the distal tubing. You can see here this just kind of coiled up that takes the fluid to whatever location we choose, either abdominal cavity, the heart, chest, whichever the case may be for the individual patient. This is a schematic of what a valve looks like. It's interesting. The first shunt valve was designed by a man named John Holter, he was an engineer in Philadelphia. His son had hydrocephalus, and the treatment then was really just not very much. They would have to tap the brain with needles every once in a while to relieve some of the pressure. But he made this valve himself, and they sterilized it, and they tried it on his son, and it worked. But essentially, that design that was used for that shunt is very similar to what is used in all the modern valves. And what it is that there's a spring in here, and the spring puts a little pressure on this ruby ball here you can see in the center. So when the fluid enters, it comes in, and when the pressure rises above a certain level, it pushes the ball up against that spring, and when the pressure falls, the ball just comes down and closes, and that opens and closes and lets fluid either through or not, depending on the pressure. There can be other devices that are added on, like the devices to prevent the siphoning effect, where the fluid can just be pulled out of the brain, if you will, like you were siphoning gas from a car gas tank. But this is the same kind of mechanism that Mr. Holter designed many, many years ago. This actually happens to be a programmable type of valve, and this little circular thing here can be changed, and it changes the amount of pressure that is applied to the spring. That's how the pressure varies. These are two examples of different types of shunts, different manufacturers where they have programmability. So you have this valve has 5 different ranges. This one has 7 plus an additional higher setting that's rarely used. So there's different valves that have different capabilities, but they all are set to drain fluid along certain pressure ranges. As you can see here, the lower settings drain more fluid. The higher settings have more resistance. It's harder to move that ball, so less fluid drains. So that's generally how shunts work. Most shunts are placed on the right side. I asked that question a long time ago to one of my mentors. I said, why is that? And he said, well, most surgeons are right-handed. But there's other reasons too. Most of the right frontal lobe is a fairly quiet part of the brain. It's not like it's doing nothing, but there's not a lot of eloquent functions where you can put your finger on it and say, oh, this is what's controlling your right hand or your vision or other important things. So if there was a complication as a result of a catheter placement, you wouldn't want to cause a major problem. So that's why most catheters are placed in the right frontal region. They typically are placed in the frontal horn, and you can see here, this is a schematic. The catheter goes in, it's in the frontal horn. The reason being is that in the frontal horn, if you can put it in the front part of the frontal horn, there's none of this, which is the choroid plexus. This is the structure that, on the right picture here, this is the structure that makes the spinal fluid. It's called the choroid plexus. It kind of looks like a fish gill almost, but it kind of floats around. It's attached to the brain, but it kind of moves around a little bit. And if you put the catheter right here and it's laying right on top of that, then that has the ability to, it'll just start to move in and it'll surround the catheter tip and eventually start to choke it off. So that's why we try to put the catheter, say, in a place up here where there's no choroid plexus to minimize the likelihood of a shunt obstruction in the future. When we put a shunt in, this is kind of a drawing about how it works. People always ask, well, how do you get it from here to here? And I'll show you that in a second. But this is, how the child's position. This is before we get prepped. But, you can see that we're getting ready to put a shunt in. Just usually supine, and we kind of mark our incisions. We try to shave as little hair as possible. And then it just involves a lot of preparation with skin prep to minimize the risk of infection. And this is, we use this rod. It's called a tunneling device, but essentially here it is here. This is what, during the surgery, we only kind of have parts of the patient exposed, but all this is covered up with kind of protective dress barriers so that to minimize the risk of infection. And once the incisions are made, this little tunneling rod is kind of guided up by the surgeon from point A to point B, wherever they are, to connect the two. And then the tubing is placed down the middle of that and it's passed underneath the skin. So that's how that works. Sometimes you can see it maybe very close to the skin in some kids, but most kids, you might see it travel across the collarbone because the skin's pretty thin there, but across the rest of the abdominal wall, chest wall and abdominal wall, sometimes it can be very difficult to see the actual shunt catheter. And here's an example. Here's a little boy that was born. You can see again, the head circumference was 50 centimeters, which is very large when the child was born. The average, again, is about 35 centimeters for a boy born at term. So it's much, much larger than normal. His fontanelle was very tight, very tense. It was, you could push in it, but you could feel it pushing, trying to push back at you. The sutures themselves were separated. I mean, the head was growing so quickly that the bones were starting to push apart. And in some ways that's good because it protects the brain because it can alleviate some of the pressure, but it's not something that we can kind of let happen for very long. But otherwise, this child had a normal newborn examination. So we here's an MRI. You can see all of the CSF. This is a pretty severe case of hydrocephalus. And just based on the child's anatomy, we didn't feel that this kid was a good candidate for an endoscopic procedure, so we opted to place a shunt. And that's what he had. So a right frontal ventricular pacing shunt. This is what a shunt series looks like. This is an X-ray, a set of X-rays. You can see the shunt tubing in the brain. Here's the valve, and then the tubing travels down around the side of the head through the neck, and then you can see it continue all the way down. And there's generally lots of excess tubing here in the abdominal cavity to allow for growth. And you can see the MRI months afterwards, where the brain is much thicker than it was before. The ventricles are also much smaller. And you can see that even the back part of the brain here, the cerebellum, looks so much different here. It was just getting squashed down by all this fluid, so it looks like it's flattened here, and now it's kind of resumed a much more normal configuration. Now, this is a long-term chart, so this is out to about 18 months almost. And you can see where initially it was very high, the head circumference, and then it comes down once the shunt's put in. and eventually it starts to grow, and it's still above the 97 percentile, but you can see it's starting to grow parallel, very close to parallel to this growth line. So it's kind of resumed a more normal um, growth pattern. So some might ask, well, these ventricles still look big. Why are we happy to live with this? As a surgeon, why do you want to do that? And the question is, that's a good question that we get asked a lot. We want the shunt to drain as much as we need it to drain. We don't want to drain everything. We need CSF in our brain. We want the head to grow like this. If you drain too much fluid, the head growth can stop. The sutures, the bones in the skull can start to close too early, and that can lead to some long-term problems. So we don't want to drain all the fluid. That's not the goal here. We want to alleviate the pressure, get the head growing back at a normal rate, and also take care of any of the signs and symptoms that might have been present at the time that the diagnosis was established. So that's really the goals of surgery, is not to have a scan that shows no fluid at all. Sometimes the ventricles do get quite small, but not always. It's not always, that's not what we're striving for in every case. So, most kids that have shunts, they work well. They come in, you know, after the shunt's put in, there's maybe more frequent follow-up for us to just check on things as they're recovering from the surgery. But eventually most kids they get on as they get older, an annual or every couple of year follow-up schedule where they'll see their their surgeon or a member of the surgeon's team just to make sure everything is going okay. And that's what happens with most kids. They come and go and they go on and live their lives. But some kids can and some patients can have a lot of complications with shunts. That's one of the drawbacks of a shunt. So, it's just like if you have the finest car or the nicest watch, eventually it can fail. Something can go wrong with it, just like a shunt. If you put a shunt in a beaker in a laboratory and ran water through it, it'd probably run for 100 years. But when you put it into a biological symptom where there's tissue like the choroid plexus, it can clog up the shunt. That can lead to complications. So it can be a very difficult, problem for some children. I know some kids that have had several shunt revisions in the first few years of their life, and others that don't have one for 20 years. So it can vary widely. We do know that on average, if you look at a lot of people that have shunts, about 25 to 40% of children will have a shunt that fails within the first 2 years of insertion. And there have been studies that have shown that by the time an infant with hydrocephalus who was shunted as an infant reaches kindergarten, they've on average will have one or two shunt revisions in that short time span. So it's not in every child, but that's just kind of the law of averages. Um, so, when the shunt fails, oftentimes they'll have the same symptoms that occurred when the shunt was putting in. Obviously, the symptoms will be different if you had a shunt placed as an infant and then you have a shunt malfunction at 10 years of age. Our brains are different at those two different epochs in our lives. But headaches, vomiting, lethargy, they're still the cardinal features throughout all ages. And if you start to have a lot of that with a shunt, that might indicate that there's a shunt problem. But altered mental status, again, rapid head growth in an infant, that might indicate that the shunt's not working as well as we want it to. And once that's diagnosed, if you come into the ER, we'll work that up. You get either a CT scan or an MR ventricle or some other type of imaging to look at the ventricles themselves. Usually we'll get an X-ray of the shunt to make sure there's no breakage of the shunt. And if we have an old scan that shows small ventricles and a new scan that shows that they're considerably larger, then that makes us concerned that there may be a shunt problem. But it's not always that easy. Um, the most common reason for a shunt failure is that the tubing inside the brain gets plugged up with some tissue. That's about 75% of cases. So that's why we try to do everything we can to put that catheter in a place where it's least likely to become obstructed. And then one of the other problems that can happen with the shunt is a shunt infection. Depending on the institution, most major hospitals have shunt infection rates in the low single digits, 2, 3, 4% at most. Anything above that is really, high. Those numbers don't mean anything though to families. If it's your child, it's 100%. So that's something that's, we just dread. I mean, fortunately, the infections that occur are usually treated successfully with antibiotics. The problem with the shunt infection is you cannot cure the shunt infection with just an antibiotic. The whole shunt has to come out. You have to have a period usually of external drainage where the CSF is collected in a collection system by a temporary drainage tube from the brain, and then you have to go back and have a whole nother shunt placed again. So it's a lot of surgery. It typically can be 7 to 10 days in the hospital. It's not something that anybody wants, and it can be a big problem. The good news is after about 3 months of the surgery, it's the incidence of shunt infection goes way, 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 way down. So by 6 months, it's really unheard of, almost unheard of for a child to present with a shunt infection. If you had a shunt operation in January, most almost all shunt infections are going to occur within 6 months of that time. So when you get beyond that 6 month date, it's usually a good indicator that you're almost out of the woods there. So I get calls all the time. The kid's 2 years out from his shunt, and they said, "Oh, he has a fever. I'm worried about his shunt." It's oftentimes not the shunt at that point. Usually we have you check with your pediatrician, make sure it's not an ear issue or some other more common reason for an infection. But if we're not sure, then it's something we have to think about. It could be a shunt, but again, that far out, it's not very likely. And there can be lots of other complications. You can have a shunt that's working just fine, but I mean, physically it's draining, but you can drain too much and overdrain, and that can lead to hemorrhages in the brain, which is a problem. You can also have a shunt that's working just fine, but you need more drainage. So it's under draining. It drips, but it's just dripping too slowly. And in the modern era, where if we have a programmable shunt valve, then we can oftentimes just change the setting to allow for more or less drainage, which will take care of usually those problems. But not everybody has a valve with that capability. Sometimes the shunt may not be placed very well. It happens rarely, but it happens. It may be partially lodged in a part of the brain where it doesn't have good access to the spinal fluid, or it may not be in the best place in the abdomen. And if that's the case, and the fluid just can't get through it, then it has to be fixed. Rarely, sometimes the catheter can migrate into like the intestines. That's usually a thing of the past now because older shunts had some metal within them that kind of make them a little stiffer before the modern plastics that shunts are made of were developed. So the things they had in the past were much weaker, so they had to strengthen them up. So they would sometimes erode into the intestines, and when that happened, the shunt you can see is coming out of the baby's bottom here, which is not obviously not a good thing, and needed to have that fixed. And then sometimes the shunt just breaks. Here's a teenage girl. You see the shunts in her brain. Here's her valve. You can see the little stump here, maybe on the picture where my red light is. And then there's nothing going down because the shunt broke right here. So the distal catheter separated, and she has what we call a distal malfunction. So we had to go in and put a new distal catheter in there. So there's lots of potential reasons that shunts can fail. Um, they are common procedures. We put a lot of shunts in for the treatment of hydrocephalus, and they can be subject to both short-term and long-term complications. But the good news is that most patients with shunts experience few of those. Seems that there's just a handful of people that have more of these complications, but it's something we always need to be on the lookout for. Um, it's unfortunate, but shunts can fail, and repeat surgeries might be necessary for children and adults that have hydrocephalus and it's treated with shunt. And again, the most common reason that shunts fail, it's because that catheter within the brain becomes obstructed. So that's kind of what I wanted to talk about with shunts. I know there's a lot more to say, but I just wanted to touch on the high points. And now I wanted to kind of shift gears to just some other treatment options for hydrocephalus that many on the call may have heard about. And one in particular is what we call an endoscopic third ventriculostomy. And this is where we can use an endoscope. And this is an actual picture of the brain, inside the brain, through an endoscope, like being used here in this surgical image. So this is the story of endoscopic third ventriculostomy. This is how it works. This is again another schematic of how our brain is. So the lateral ventricles, the third ventricle is right here. You can see in the middle. This little arrow is where the fluid goes into the cerebral aqueduct and it travels down like this into the fourth ventricle, and then the fluid gets out of the brain and it moves around the brain with all these little white arrows, and eventually it gets reabsorbed along the top of our heads and it goes right back into the venous into the blood vessels here you can see, and it goes back into the bloodstream, and that's it. That's how it works. Um, if there's a blockage, let's say right here where my red light is, and the fluid can't get out any longer through the third ventricle, then it builds up here, and that's a problem. The fluid here gets out like it normally should, but up here it can't. So we need to do something to take care of that. You could put a shunt in and drain the fluid. That's one solution, but there's perhaps a more elegant solution in these cases where you can actually do what we call an endoscopic third ventriculostomy, where if you make a little opening, say right here in the floor of the third ventricle, and the fluid then can get out this way, where this little arrow is, instead of going all the way down this way and around, you accomplish the same purpose. So that's what an endoscopic third ventriculostomy is. It's essentially an internal bypass. It's a little hole that's made right here to let the fluid go from here to here, where it eventually gets into that space where it can be reabsorbed. The third ventriculostomy, Dero, just is a contraction of third ventricle and ostomy. Third ventricle is the anatomic site where we make the opening, and ostomy is just a medical word for ostomy or for hole. So third ventricle ostomy or third ventriculostomy. That's what ETV is. The endoscopic for is what the E means. So that's really simply what an endoscopic third ventriculostomy is. It bypasses some area of blockage in the ventricle, whether it's in the aqueduct, if it's in the child with a fourth ventricular tumor, or if they have a Chiari malformation here where the fluid can't get out of the brain. These are all indications for endoscopic third ventriculostomy, just by creating a new passage for fluid to exit the brain. This is one situation where patient selection is critical. You could do third ventriculostomy on a child that has communicating hydrocephalus. It could go beautifully. It's just not going to work in most cases. So that's why we need to properly select the patient. I showed these slides earlier. This is a child with a tumor that's blocking the fluid getting into the fourth ventricle. This is an ideal candidate. We did a third ventriculostomy to get things settled down before he eventually went back and had his tumor removed. Here's a child with another type of tumor that can't be removed, but causes hydrocephalus. You can see the big ventricles, the lateral and third ventricle are big, the fourth is very small. If we make a little opening here, then we can accomplish the same thing as a normal person without this blockage, because the fluid then gets to where the space where it needs to be reabsorbed. And here's another example of a young girl with a Chiari malformation where all these passages are open up here. The fluid can't get out of the brain down here, so we make another opening up here to let that happen. So these are places where it's very likely to work. Um, we know that in certain age groups, it doesn't work very well at all, though, particularly in children under 6 months of age. And there's lots of different reasons that people think that is, that the subarachnoid spaces around the brain just aren't as well developed yet, and other reasons. But it's been shown in multiple studies where if you're under 6 months, it doesn't work as well. They can add other treatments to that where you can go in the brain and try to coagulate the choroid plexus to make it work, but another discussion, a different topic. So these are kind of what the scopes look like. Some are bigger, some are smaller. This is a flexible scope, so it actually bends around so you can look around corners. There's lots of different technology from different companies, but this is essentially how we do it. We plan the opening. So this is, where the fontanelle region is, somewhere up here. It's a little bit off to the side, but that's generally where the opening is made. We put a camera into the ventricle, the endoscope into the ventricle. We go through the foramen of Monroe, which is another opening in the brain, and we're looking right down here. This is the target point right here. Here's the third ventricle, and this is the floor of the third ventricle. We have to be very careful. This blood vessel is called the basilar artery. About 30% of the blood going into our brain comes up through this artery. If you were to damage that during that surgery, it could be life-threatening. It's something we avoid at all costs. Fortunately, it's extremely rare for that to happen, but sometimes if the artery is very big and it's blocking that area, then we can't do the procedure. But that's why patient selection is important. But this is generally how it works. So we put a camera in, and then we kind of get into this area where we make that opening. I'll show you an example. This is what it looks like when the camera enters into the ventricle. You can see the choroid plexus. This is the foramen of Monroe, which connects the lateral ventricle to the third ventricle. So the fluid goes from here and it goes through here into the third ventricle. These are some important landmarks we look for when we're doing the procedure. And then this is what it looks like inside. This is the floor of the third ventricle, kind of as if you're just walking in there, looking down at and standing on the floor. This is the front would be up here. This is the back. This will be the right, and this will be the left. And this red dot is the target point. Here's the big blood vessel I talked about. You can see it usually because the membrane is very thin. If this was all red and all blood vessel, then we wouldn't be able to do the case because it would be too dangerous. And these are some other important blood vessels off to the side. But this is the target point right here. We call that the tuber cinerarium, but that you can see it's very thin. This is the bone of the skull up here. So that's why it looks white. But this membrane is very thin here. You think, well, why doesn't it just pop open on its own? If you have hydrocephalus, it just doesn't. For some reason, it just stretches out, but it won't open up on its own. But we have to help it. So that's why we make the opening right here. And then the CSF can get out this way instead of where it wanted to go out. That part of the brain is blocked off. So this is kind of what it looks like. Again, this is an image. You can see this is our target point. Here's a little probe that comes in. We pop through to make it. We use a special balloon that kind of dilates. This balloon's about 3 or 4 millimeters in diameter to make that opening a little bit bigger. And then once we look inside, we can see here's that blood vessel. So we know that we're in that space there. And then this is essentially, again, this is the way it works. Here's the kind of the trajectory that we select and use. Oftentimes use a navigational tool to help us get precisely to where we want to start and finish, just to make it a much more precise and much more safe procedure. Typically, here's the entry point on the head, just a little bit off the midline, a little bit in front of the coronal suture. Right, just in a little baby, the fontanelle's right here, so it's a little bit to the right of and a little bit anterior to that point, and this is the trajectory. And this is what it looks like when we enter. This is the choroid plexus. You'll see it in a second when it starts to move. And that's just guiding the endoscope in. This is the floor of the third ventricle right here. You can see it starts to look very thin as I get closer. Here's the blood vessels right here. So there's plenty of room for us to come in and make that opening, which is going to be right about there where the red dot is. This takes you to the pituitary. Here comes the probe. And you can see you'll see the pop, that little shutter there. That pops through that little membrane. It's tougher than you think. And then we just stretch it out a little bit with this, and then the balloon will come in, and you'll see in a second. And the surgery itself can be very quick. It can take, once you're actually making your skin incision and doing the third ventriculostomy and closing, it can take 30 minutes. And there you can see on the way how that looks on the inside there. Those blood vessels that we talked about. Sorry about the video, it's a little slow here. But you can see how it looks nice and clean down there, so that fluid now can get right out into that space where it needs to get to be reabsorbed. You can see why those vessels are right there and why that we have to be very careful and know exactly where they are. If you really can't see through that floor, you really can't do the operation. It just could be too dangerous. So that's essentially a third ventriculostomy. That's how it works. And here's another example. This is a girl that had a brain tumor. She had surgery to remove her brain tumor, but eventually the tumor came back, and you can see here this tumor was, and it was a highly aggressive type of cancer. We couldn't really operate on it because it was just going to be too risky for her. When she developed hydrocephalus, you can see over the matter of a few months, she went from having small ventricles to bigger ventricles to much bigger ventricles. And when she came back in at this point, she was quite sick. So we offered a third ventriculostomy. We could have placed a shunt. That would have worked too, but be nice to do something where we wouldn't have to leave a permanent device behind. So we did an endoscopic third ventriculostomy. And here's the video again, just to give you another example of how this looks. Here's that scope is coming in right to here. Now it's in the third ventricle. You can see the floor of the third ventricle right here. And then I'm going to turn the scope back in a second, and you'll see when we flex the scope backwards, you'll see the tumor just kind of sitting there blocking the normal passages. It wasn't the goal of the surgery to take that out. And then we just made the opening right here. And this is the probe. You'll see it kind of pops a little bit when you pop through there. And then we use the balloon to make it larger. Sometimes you have to do it a couple times just to get it to the size you want. But that's really what a third ventriculostomy is. And you'll see in a second here, once we get this opened up, there's another little membrane we have to deal with. But then there's that other membrane we have to open up or it really won't work. You can see how that's in the way. So we open that up as well. And then once that's open and dilated, you'll see that the blood vessels in there like we talked about. And then we're done. And this is kind of compressed, obviously, but this takes about 20 minutes for all of this. And you can see the blood vessel right there. So that red thing pulsating like that is the basilar artery, which is this big white thing right here on the right picture. But that's the way it should look. We can have a nice clear view down. That's where the fluid needs to go. So that's how we do a third ventriculostomy. And she went home the next day. She didn't have any hardware put in. And you can see weeks later, the ventricles, her symptoms went away almost immediately, and her ventricles got much better. So most kids stay in the hospital for, overnight, usually go home the next day. Complications are rare. The biggest worry is that injury to that large blood vessel, the basilar artery, but if we see that it's in the way, we just can't do it. It's just not safe. So fortunately, that's very, very uncommon to encounter that. Risk of infection, again, is much lower than even with shunts. So complications in general for this are very rare. So that's why it's a nice option. It's not, panacea. They can sometimes fail. In children to present with really large ventricle, where they're super large, that membrane at the floor of the ventricle can be really stretched out. And then once the fluid is drained, it kind of unstretches, if that's a word, if you will. And the opening that you made can kind of get a little bit smaller and smaller. And sometimes the edges that are sticky stick together and they close up. I've had two or three cases like that in my career where you do that, it happens. They come back within a month or so, you reoperate, do the same thing over, and then it works the second time much better because the ventricles have gotten a lot smaller. So sometimes that's necessary, but not frequently. Success really depends on a couple factors. Number one is age. So less than 6 months, we know it's much less likely to work. It can work in certain situations, but not all. So about 50% of the time it'll fail under that age group. So some families are willing to take that chance, but um, if it doesn't work, then most those kids will need to have a shunt. We know it's also less likely to work in kids that have spina bifida, if there's a history of an infection, or if there's a history of an intraventricular hemorrhage. And the best kind of examples of like a teenage person that has a brainstem tumor that was just recently diagnosed, or if they have aqueductal stenosis, those persons generally do much, much better. Um, and again, um, we're not curing the hydrocephalus in these cases. It's a very nice solution to the problem of hydrocephalus, but there are rare reports of people having bad headaches. They go to an ER somewhere and they say, "Oh, I had an ETV," and like, "Well, you're cured. You don't have to worry about it. It can't be hydrocephalus." And they send them home, and then something bad happens. So, if, 3, 4 years later, if somebody starts to have severe headaches, you need to get in touch with your neurosurgeon just to make sure everything is okay. And but so um, generally that's doesn't happen, but this if the symptoms start to come back again, it's possible that they can fail down the road. There's a nice thing that we call the ETV success score where we can actually predict how well it's going to work. And you can see there's three things that we look at: the age of the patient, what the reason for hydrocephalus is, and whether or not they've had a shunt in the past. So for this boy who was 16 years old and had this brain tumor in his midbrain and aqueductal stenosis because of that, you can see there's no aqueduct here. And his fourth ventricle is small. These were really big, the third and fourth ventricle. So he's older than 10. He's got aqueductal stenosis or a tectal tumor, and he never had a shunt before. 90% chance of success, and that's very good odds for that. And that's why we really think this is really the best option for somebody with this kind of problem. You can see though, if you're a month old and you had a hemorrhage, that it's a much different story. So you can see that you get 0 points for your age, you get 20 points for hemorrhage, and you never had a shunt. So it's like a 30% success rate. So that's why, you know, a lot of people won't even try that because it's much less likely to succeed. So, I mean, these are decisions that are made individually with the families of these patients or adults that have these, so teenagers that have these things. So it's on a case by case basis, but this is very helpful in helping us decide which may or may not be an option for a particular patient. So regardless of how it's treated, you know, one thing that's generally necessary is regular follow-up. The timing of that varies amongst providers, amongst patients. It really depends also on the time of where you are in your life with your history of hydrocephalus. If we put a shunt in somebody today, they're going to come back and see us fairly frequently for the first few months, a couple weeks after surgery, maybe 4 or 5 weeks after that, and then, 2 or 3 months down the road. But eventually try to get out to like an annual schedule or so for most people when they're young. And then when you get older into your teenage years, every couple of years, and sometimes even longer than that. So it really depends on the individual. It also depends on the surgeon, what their preferences are, and how that works. Sometimes when you come in, we may uh, suggest some type of imaging just to take a look at the brain, make sure everything is okay. We might check a shunt series from time to time, particularly in somebody who has a big growth spurt where they've grown, particularly in high school, teenage boys or girls when they get to be older. Is there enough tubing in the abdomen? Generally, there is, but it's something we need to keep an eye on. But in general, most people that have shunts can do just about anything that they say. As a neurosurgeon, I would say I never see a reason why anybody should ever go bungee jumping, but for some reason people like to do that. I certainly wouldn't try it, but But God bless you if you do. Good luck. But that's one of like where there's like a sudden violent kind of change in your position, or that's something I worry about. Fortunately, that doesn't happen very often for most of us in our lives. But if you play like a high impact sport like tackle football, where somebody's out there trying to take you down, hit you hard, those things have a much higher likelihood of causing a problem with the shunt than somebody who's playing tennis or basketball or something like that. So, there are certain things like football, wrestling, in boys and girls, but other events like tumbling, where you're like really like not just doing a couple somersaults, where somebody's really like an active tumbler, where it can put a lot of stress. Trampolines, even, if you're doing a lot of flips, not just jumping up and down. So have a talk with your surgeon. Some surgeons have different ideas on that, different preferences, but it's really, again, needs to be individualized. But I generally tell most people they should live the life that they want to live, with certain precautions, but not too many, as far as I'm concerned. And again, when to seek medical attention, red flags. So if you start to have severe headaches, you need to let somebody know about that. If you can't get in touch with your doctor, just get to the ER, have somebody check it out. Um, everybody has a headache from time to time. They're not always shunt related. So sometimes it can be difficult to sort that out. But the longer you have a shunt, generally you start to know what might be your usual pattern. If you take a headache, if you have a headache, a mild headache, and you take a Tylenol or you take a little nap, you wake up, it goes away. It's probably just stress or something else. But if it's getting worse, not responding, then let somebody know about it. And if you start to have headaches and vomiting, or headaches and say blurry vision, or if you're getting a little drowsy, somebody's worried about you, you're not as awake as you should be, then these are other warning signs that you really need to pay attention to and seek help. If you've had a malfunction 3 years ago and those same symptoms start to come back, obviously that's different for every person. But usually, if you have a shunt malfunction, the symptoms you have are very similar if you had another shunt malfunction. So just something to keep in mind. If there's any pain or redness or swelling along the shunt, that might indicate broken tubing or perhaps even an infection. And if you have a fever, but usually it's more common if that be a problem if it's something that's relatively close to the time of the surgery, not necessarily, you know, 3 or 4 years later. So just to wrap it up, my last slide, shunts are the mainstay of treatment for persons with hydrocephalus. It's interesting though, because their design, their style, the way they work has changed little since they were developed in the 1950s. Most people that have shunts do well. The vast majority do, but some unfortunate few face a lot of problems and have many more malfunctions. But even if it's going well, there's a lifetime of care that's associated with shunts. So you'll need to see a provider periodically for the rest of your life, probably, if you have a shunt. So it's just something else that we keep in mind. Endoscopic treatment is now widely accepted, but and it's been known to have high success rates and relatively low complication rates, but it's not for everybody. Patient selection is critical. It can only work in certain indications. But they're starting to expand lately. So now children that have communicating hydrocephalus, if with the addition of coagulation of the choroid plexus to try to diminish the amount of CSF production, you can actually um, expand the role for ETV so that it can be used in certain other indications where in years past that wasn't necessarily thought to be the case. Um, but if it's the right patient, you can treat that patient endoscopically, then you can potentially do away with the need for a shunt for the rest of your life. So I think that's all that I have. I wanted to say thank you again to the Hackett program, and thank you for joining us for tonight's seminar. Happy to take some questions.